This discussion is going to center on anti-inflammatory drugs. So we're going to be looking at both over-the-counter and prescription anti-inflammatory drugs, looking at both non-steroidal anti-inflammatories and also looking at corticosteroids and kind of how they work with the body and what some of their purposes are. Okay, just a basic overview of NSAIDs. Again, make sure you're reading your chapter to kind of go along with some of the things we're talking about here. Non-steroidal anti-inflammatory drugs. So these are non-steroid-based anti-inflammatories. Aspirin is a medicine that works through a similar mechanism as NSAIDs. And they both work through inhibiting what's known as the cyclooxygenase enzyme, or the COX enzyme. There's two different COX enzymes. One is the COX-1, which is basically what they call a housekeeping enzyme. And this is pretty much involved in a lot of different body processes, particularly the formation of the gastric mucosa to protect the gastrointestinal tract and in blood clotting. The COX-2 is what primarily functions in the classic inflammatory response. So when you take an NSAID, most NSAIDs are going to block both of these, and there's some charts and everything kind of showing the physiologic action as to how this works. Okay, so for the inflammatory response, so a lot of the substances produced are going to regulate a lot of the actions of the inflammatory response and also cause a lot of the signs and symptoms. So one question, and most of you probably know this even without looking, but if you're unsure, it's in the book, and I want you to answer this as an assignment on Blackboard. What are the 5 cardinal signs of inflammation? Okay, so make sure that you look to answer and address that as a part of your assignment. Some of the specific chemicals that we're going to look at, your prostaglandins, they're basically chemical mediators that work in a lot of different body processes, and some of those are listed on here. Your thromboxane is functions with blood clotting, so it stimulates the activation of platelets, and your leukotrienes stimulates white blood cell activity. So obviously we know during the inflammatory response, white blood cells are important for kind of managing a lot of the processes, particularly the phagocytosis of the cellular debris and everything that happens, particularly when you're talking injuries. And drugs, this is what a lot of your asthma drugs that get used, because asthma has an inflammatory response. This is what a lot of the asthma drugs typically use to inhibit are your leukotrienes. So with the inflammatory response, as far as the 48-hour question, when we look at the process of what goes on, and we'll reference this in regards to an orthopedic injury, within 48 hours you actually start to get into what's the next phase of the whole healing process, which is your repair regeneration phase. You do start to get some collagen fibers getting laid down. Remember, you have the inflammatory phase, the repair regenerative phase, and the remodeling phase, and don't forget those phases kind of run into each other. So you actually do start to get a little bit into that within a 48-hour period, typically. Obviously, it would depend on the severity of the injury as well. As far as the intrinsic versus extrinsic factors, I'd just like you to look. There's a table in your textbook on page 33, box 3-1. Kind of look at those factors. As far as the chemical release, we talked about some of the enzymes. There's other chemicals that will get released. Chemicals such as bradykinin, histamine. Again, the leukotrienes, prostaglandins, thromboxanes we kind of talked about already. Again, they're going to contribute to a lot of the signs and symptoms of inflammation. So, for instance, the pain that you experience as one of your signs of inflammation will be caused by, partially caused by the release of bradykinin, which is a chemical substance that irritates nerve endings. Histamine is going to contribute to the swelling that forms because of the increased permeability in the blood vessels. Now, we talked about the action of the white blood cells and what they do. There's good things to that and bad things to what the white blood cells do. Now, early on in the process, it's believed that a white blood cell called neutrophils are released in the early inflammatory process. Again, they work to eliminate some debris. The problem is their action also causes the formation of what are known as free radicals. So those free radicals also have a tendency to go and do damage to other healthy cells in the region as well. So again, we need the inflammatory response in order to heal. The problem is some of the side effects of it can inhibit or not necessarily prevent healing, but will definitely slow it down. Remember, everything is going to heal at some point. It's just a matter of how we manage it and controlling the inflammation process. Not so much eliminating inflammation, it's controlling that's going to be important. So a lot of what we're going to be looking at here focuses on acute inflammation, but a word about chronic inflammation is we know that a lot of times with orthopedic musculoskeletal related injuries, we encounter a lot of chronic, more persistent pain type issues, and there's different physiology coinciding with that. Usually when you look at your more chronic based situations, you're usually looking at some type of issue with vascular disruption and tissue hypoxia. So basically because of the overloading of the structure, and we commonly see this with a lot of tendon conditions, there is a disruption in the normal circulation and therefore the oxygen that's getting to the tissue. So it creates what's essentially a failed healing response. And that is basically going to create a situation where in a lot of instances the tissue starts to degenerate and you start to get some markers of tissue degeneration. And actually even in some instances what we think of as classically chronic inflammatory conditions actually aren't chronic inflammatory conditions. They're actually more of a breakdown condition. So clinically, you just have to kind of watch how you kind of treat and address that situation. So if you see this flow chart, this basically kind of goes through what goes on with the inflammatory process. So it kind of takes you through from the beginning to where the cell membranes get disturbed all the way through some of the other chemical release. We talked about the interactions with cyclooxygenase. So we have the breakdown of the cell membrane, phospholipids get released, and then you have kind of a split off with cyclooxygenase and lipooxygenase. And if you notice on this chart, it's also showing different blocks. Those blocks are where different anti-inflammatory medications work. So block 1 is where your corticosteroids work. Block 2 is where your NSAIDs work. Block 3 are actually the anti-inflammatory drugs used to treat asthma. So this kind of shows that breakdown along with some of the chemicals that we've talked about earlier. So prostaglandins are one of the main chemical messengers that are going to be affected by the use of anti-inflammatories and the process of inflammation. And again, prostaglandins mediate various processes in the body. And some of what we look at being mediated and controlled by taking anti-inflammatory medications is a good thing. Other things not so much. So you see here we have various functions and make note of those different functions of prostaglandins. In reference to acute and chronic inflammation, so your therapeutic uses of your anti-inflammatories, it can be used for both. Again, clinically, you just have to watch. Again, a lot of your more chronic pain type things could be more degenerative based and won't necessarily be applicable for using anti-inflammatories with. All forms of anti-inflammatories, I mean, if you look at over-the-counter anti-inflammatories, and we're going to cover a couple different types, they're all essentially equally effective in what they do. It just sometimes that the patients respond differently to some than others, and this will be a point that we talk about in a little bit. And the doses are just going to vary as well. But for the most part, they're all equally effective. As far as what they do, they help in reducing pain, swelling, stiffness. They have antipyretic properties. They also reduce platelet aggregation, so they also reduce clotting. So you have to be aware of that as well. So the clotting time will not be quite as quick, particularly if a patient is on a high dose of anti-inflammatories. And as far as the time frame, so like I said, patients respond differently to different anti-inflammatories, you should have a time frame of about 1 to 2 weeks. If a patient doesn't respond to an anti-inflammatory within about a 1 to 2 week time frame, try another type. I've seen this many times before where an athlete may not respond to ibuprofen, but they respond to naproxen, or they don't respond to naproxen, but they respond to ibuprofen. So, give it about 1 to 2 weeks to work, and taken consistently. And then if it doesn't work for the individual, then try another one. So the pharmacodynamics of non-steroidal anti-inflammatory drugs. You can see here, again, that breakdown of going from tissue injury, very similar to the chart shown earlier. You can see where different NSAIDs will work. Now, we'll talk about the difference between your typical NSAIDs and what are called your COX-2 inhibitors. So the COX-2 inhibitors only inhibit the formation of COX-2, okay, which are the inflammatory prostaglandins that work in the typical acute inflammatory process, whereas your other NSAIDs will prevent the formation of COX-1 and COX-2. Okay, now the drawback to that would be that your protective prostaglandins will get blocked with that as well. You also have your leukotrienes, which function with controlling bronchoconstriction as well. So again, the chart here is showing you where NSAIDs and aspirin work. An important point, again, the leukotrienes. Some asthma patients will be very sensitive to anti-inflammatory drugs. The reason for that is if COX-1 and COX-2 get inhibited, it kind of allows the expression of leukotrienes to become more prominent, so they'll be more prone to having a bronchoconstriction episode. So that's an important thing to look at when you're dealing with asthma patients as well, to realize the fact that some asthma patients may have difficulty with taking anti-inflammatories, and it may make them prone to having more asthma attacks. Some simple points about pharmacokinetics. Most of your anti-inflammatory drugs pretty rapidly absorbed from the gastrointestinal tract, usually within about a 30-minute time frame. It's a good idea to not take them on an empty stomach, because they can possibly cause gastric irritation. That could potentially slow down the absorption a little bit, but again, if it's better than ending up with an upset stomach from taking them, they get metabolized by the liver, and they're able to cross the blood-brain barrier and the placenta, meaning that they do affect the neurological system, and that will be part of the situation in as far as how they block pain. But this can also cause issues with pregnancy. So again, if you are dealing with a pregnant patient and you're giving them advice on anti-inflammatories, it's a good idea to make sure to check with their physician. So aspirin is a typical anti-inflammatory drug. It's a derivative of salicylic acid. Its uses: fever reduction, anti-inflammatory, analgesic pain relief, and antiplatelet properties. A lot of people will take low-dose aspirin who are at risk for heart attacks. So the antiplatelet properties kind of, if you will, thin the blood and prevent issues with that. The antiplatelet effect can have both positive and negative effects. It's important to know that this can last for about 4 to 6 days, even once the medication is discontinued. So if you have patients who are going in for surgery, a lot of times it'll be suggested that about a week up into the surgery, they discontinue the use of any type of anti-inflammatory drug that could thin their blood and cause prolonged bleeding time. And again, that prolonged bleeding time is going to occur due to the fact that the thromboxanes get suppressed, which is going to inhibit platelet activity. So your various routes of administration for aspirin, aspirin comes in all different types of forms. Oral-wise, tablets, caplets, chewables. There's ecitrin, which is an enteric coated. Basically, what the enteric coating does is it makes it easier to swallow. The other thing it does is it produces less gastric upset, because what happens is the pill is coated, and while it's in the stomach, the coating has to wear away before it gets absorbed, so it reduces the amount of gastric upset. It's also available in powders. It's also in rectal suppositories. The problem with the rectal suppositories, they're not used all that often. Very slow absorption. The other thing is obviously they can slip out as well. So this is some of your basic dosing information. Now, as we go through the semester, there'll be some drugs I want you to be a little more in depth. With the anti-inflammatory drugs, I want you to know a little more depth as far as the dosing is concerned, just because they're a little more commonly used. So they typically come in 325 milligram tablets. For adults, you look at 2 tablets about every 4 hours. You have your maximum for anti-inflammatory action. Some people recommend a loading dose, a higher loading dose, which obviously you will not repeat a dose in 4 hours. You'll wait a longer time before you do that. And then it's recommended that you use no longer for 10 days for pain relief and no longer for 3 days for fever. So anything beyond that, the individual should be seen by a physician. Very common to see combination aspirin products on the market, and they come in various different forms. You have your buffered aspirin. This will be used to reduce GI upset, so a lot of times they will add a buffering compound to it. It could help speed up pain relief and could also help reduce the gastrointestinal distress. There's delayed release aspirin. So again, similar thing, it'll help to reduce some of the stress on the stomach. What it does is it allows for the small intestine to do most of the absorption of the actual aspirin product. One of the issues with the delayed release is your pain relief. If it's obviously a delayed release mechanism, it can cause a little bit of a relief or delay in the pain relief. And very also common to see combinations of aspirin with caffeine. And what this does is 2 different things. One, caffeine's a stimulant, so that could actually enhance the pain relief effects. The other thing it will do is constrict the blood vessels that cause headaches. So it's very common to see aspirin combined with caffeine in a lot of your headache medicines, and that's due to the fact that the caffeine will have the vasoconstrictive effect and assist with the relief of the headache. So now looking at your non-steroidal anti-inflammatories, again, even though it has a similar mechanism, technically aspirin is not a classic NSAID. They developed NSAIDs to get the anti-inflammatory effects without some of the other side effects of aspirin. So basically it has the same actions. One of the differences is it does not bind to COX, your cyclooxygenase, irreversibly. So there is less of an antiplatelet effect. So your blood clotting will not be as affected with NSAIDs as they will be with aspirin. However, there is still a slight antiplatelet effect that will take place because of the suppression of the thromboxanes. They still have effects on your cyclooxygenase 1 and 2. We will talk specifically about the cyclooxygenase 2 inhibitors and how they work, but your classic NSAIDs will affect both, and again, that's where some of the potential negative effects of NSAIDs comes in. So your cyclooxygenase 2 or your COX-2 inhibitors, they're NSAIDs that were developed to selectively block cyclooxygenase 2. So remember, cyclooxygenase 2 deals with the chemical reactions that occur in your classic inflammatory response, whereas cyclooxygenase 1 deals with everything that are related to normal body processes. So the goal in these was to kind of limit the side effects, limit the gastrointestinal side effects and everything else that comes with the blocking of cyclooxygenase 1. And again, you could look at that chart to kind of see how this would work. The goal was to limit the side effects. Some of the more common COX-2 inhibitors, Celebrex, Bextra, Vioxx. Some were actually taken off the market due to increased risk of heart attack. Vioxx was one of them. I believe Celebrex is still utilized by some some prescribing physicians, but Vioxx was one that was definitely taken off the market. It's interesting because, and I actually had this conversation with a physician once, there's cardiac risks associated with all NSAIDs, so they sort of think that, at least the physician I was talking to thinks they jumped the gun a little bit with the Vioxx, but nonetheless it was taken off the market. So basically the COX-2 inhibitors don't interfere with the normal body processes related to what goes on with cyclooxygenase 1. So again, if you go back to that chart and look at where we showed the block where NSAIDs do their work, instead of it going with cyclooxygenase 1 and 2, it just basically inhibits 2. Some other interesting things that are getting looked into with COX-2 inhibitors are the role in tumor suppression in Alzheimer's and how COX-2 inhibitors could be utilized in these situations. So certainly no definitive use in this regard yet, but this is something that some people are looking into. Another method of application or method of use for NSAIDs is a topical means by applying it to the skin. Obviously, one of the proposed benefits of this is the fact that you're kind of going around the gastrointestinal tract, and similar to what you get with the COX-2 inhibitors, you're limiting the adverse effects on the gastrointestinal system. One of the things, though, obviously that comes about with this is that the drug blood levels are a little less than what that would be achieved versus oral administration. However, most of the absorption is taking place in the actual muscle and connective tissue. So there are also possible fewer effects on the renal system as well. So some good benefits being seen to topical NSAID application, with really the most adverse effect being a local rash. So certainly they're looking for more ways to utilize this method of administration. So your NSAIDs, your indications and uses, same properties and actions as aspirin. Again, aspirin, albeit similar mechanism, technically doesn't fall under the non-steroidal anti-inflammatories classically. Some of the differences, your antiplatelet actions are not as long-lived. They are still there, though, so again, many times going into surgery, it'll be recommended by your physician to not take any sort of NSAID within a week prior to surgery, typically. So there is the contributions to increase bleeding. Again, typically, or pretty much always, individuals who've suffered concussions will be told not to utilize NSAIDs because of the antiplatelet effects that could possibly occur. And it's still good to usually consult with your team physician on the use of this. So when you're kind of setting up your standing orders with the physician, it's good to kind of talk about some theories as to how and when NSAIDs should be utilized. And these are just some other indications and uses. Again, very similar to aspirin in some ways. You have some other applications with this, so note these other indications. So our routes of administration, we have our oral forms, which are, again, very commonly what typically gets used, tablets, caplets, liquids. Again, we talked about the topical application. There are ophthalmic routes of administration for inflammatory conditions of the eye. Topicals can also be formulated and put together by pharmacists. An example of that is the Ketoprofen cream. So some individuals will utilize topical applications when it's warranted. So looking at some different types of NSAIDs, ibuprofen, very common one utilized both over the counter and prescription. Some of your brand names, this would be your Advil, your Motrin, are just some examples of brand name ibuprofen. Prescription-wise, they could come in anywhere from 200 to 800 milligram tablets. Over the counter, only sold in 200 milligram. You have to look at the differences between your dosing for anti-inflammatory effects versus just for analgesia. For anti-inflammatory effects, you basically are going to need 2,400 to 3,200 milligrams daily, taken in 3 different doses. Analgesia could be achieved in doses less than 2,400 milligrams a day. There's also, with this, as we talked about, a less chance of gastric bleeding than with aspirin, and it can also be used for antipyretic effects. Peak plasma levels in about 15 to 30 minutes. You usually take these about every 6 to 8 hours. The half-life of ibuprofen is approximately 2 hours. So it's a very short half-life, so you have to take the dosages more often. We talked about the differences between the anti-inflammatory effects and analgesia. The key is your daily dose of ibuprofen should not exceed 3,200 milligrams. Naproxen sodium is another NSAID, very commonly sold over the counter. It's also prescribed. The most common brand name you would see for this would be Aleve. As far as the daily dosages, it is a little more potent than ibuprofen, so the daily dosages are between 750 and 1,000 milligrams. You will find these in 220 milligram tablets. Your peak plasma levels in 2 to 4 hours. This drug is primarily eliminated by the kidneys. The half-life is longer, so the difference with this and ibuprofen, you don't have to take naproxen as often as you have to take ibuprofen. The half-life is about 12 hours, so usually this is taken on a twice-a-day schedule when it is suggested to patients. Ketoprofen, brand name would be Orudis. This one is not in your text, but it is a common over-the-counter NSAID to be utilized, so I want you to be aware of it. 12.5 milligram tablets, so the dosing is much smaller. Again, however, a shorter half-life. You're only going to take typically 1 every 4 to 6 hours, definitely no more than 2, and your maximum would be 75 milligrams in 24 hours. So the overall dosing, as far as how much the individual takes with ketoprofen, is much less. Again, remember, it doesn't necessarily make it more effective per se. The effectiveness of all of your NSAIDs are pretty much the same. People just maybe respond to different NSAIDs differently. So again, you go through that 1 to 2 week trial of any sort of NSAID to see how well it works for people. And then these are just some other NSAIDs. Your book talks a little bit about these. I just like you to be able to recognize them as non-steroidal anti-inflammatory drugs. So just note these different ones and be able to recognize them. So just some further dosing and protocol notes. You want to use typically NSAIDs over the counter no more than 3 days for fever, no more than 10 days for pain. The idea there is not so much that you definitely will have something else wrong with you, but the idea that if you do have something beyond this time frame and you haven't made contact with a physician yet, you probably should. So it's a good idea that if you have an athlete or you know someone is taking the NSAIDs beyond these time frames, that they at least see a physician or talk to somebody to confirm that there's nothing else wrong. And the question I have posed here is going to be a discussion board post. What are suggestions you can make to an athlete in reference to NSAIDs? As again, these are a very prominent thing utilized by athletes. So in the discussion post, kind of note this, and I want to see what you have to think about that. So the adverse effects, very common adverse effects between NSAIDs and aspirin. So a lot of the different things that we discussed with aspirin will be relevant here. The gastrointestinal irritation by 2 different mechanisms. One, by the direct irritation of the contact of the stomach mucosa with the actual drug itself, and the other thing is due to the inhibition of cyclooxygenase 1, which is the protective mechanism of the stomach when the NSAIDs inhibit that. The antiplatelet effects, again, not as strong as with aspirin, but still prevalent with NSAIDs, so you have to be aware of that. Potential for kidney damage, liver damage. There is also the potential of reducing the effectiveness of blood pressure medications. Typical patient population, you're probably not going to see too much of an issue with that, but it is something to be remind you of. Hematological effects. You have to be careful of individuals with asthma for the reasons we discussed prior to. Again, go back to that chart, and you could see where the potential effects with asthma comes in. And then kind of a rare thing, but it can still happen with NSAIDs, is what's known as Stevens-Johnson syndrome. It's a rare disorder of the skin and mucous membranes that can develop if an individual were to have an adverse reaction. And when that does happen, it is a medical emergency. So just to kind of expand on some of the adverse effects, hypersensitivity reactions can occur with NSAIDs as well. Typically they'll happen within about a 3-hour time span after taking, and there's different types of allergic reactions. One of the points that I'm going to talk about here, I discussed earlier, the issues concerning people with asthma. And the asthma attacks are going to due to the diminished prostaglandins and the increased leukotrienes. Again, reference that chart, that flow chart, is what goes on and where the blocks occur. So essentially what happens is if somebody takes an NSAID, if it's an asthma patient who has a little bit of a hypersensitivity, the suppression of the prostaglandins kind of brings out the action of the leukotrienes a little stronger, causing the bronchospasm. So that's where that issue comes in. And then with your traditional NSAIDs and your COX-2 inhibitors, they also increase the risk of myocardial infarction in some patients. Again, that was one of the reasons why Vioxx was taken off the market, was they found a connection, albeit from what I was told a loose connection, but one nonetheless, so they removed it from the market. Some other things to be mindful of. Don't use in combination with alcohol. Again, that's just going to contribute to gastric upset. It could cause some damage in the gastrointestinal tract. Be mindful of combination meds. And the reason you have this is you have a lot of cold medications that also include ibuprofen. So again, don't double up on the ibuprofen. If you're taking a cold medicine that is ibuprofen, that's all the ibuprofen you need. You don't need to take ibuprofen on top of that. And sometimes people don't realize that when they're taking some of these medications, so it's important to be aware of that. And then as far as aspirin's concerned, don't give aspirin for relief of a fever to anyone under 18. Aspirin has been linked to Reye's syndrome. So, and what I want you to do is take a look in your textbook. What do the stages of Reye's syndrome present with? So, what would be some things that disorder would cause? So, these are some adverse effects that are commonly seen, particularly when you look at toxicity and overdose situations. So, you look at the diminished hearing, ringing in the ears, headache, dizziness, nausea, and there's some others listed on here. I'll kind of let you go through those. The central nervous system depression is more common and more prevalent with aspirin overdose. So these aren't necessarily regular side effects. This is what you're going to see when you have situations where somebody overdoses on the medications. Your contraindications for aspirin, pregnant women, They should not take aspirin. As far as NSAIDs are concerned, they should only take with advice from the physician. Many times physicians will discourage the use of NSAIDs during pregnancy. They're not a complete contraindication, but women should check with their physician before they take NSAIDs when they're pregnant. People who have a history of any type of peptic ulcer disease, GI bleeding, or liver disease, people who have nasal polyps, people with tartrazine dye sensitivity, asthma patients, and do not combine with alcohol consumption. Those are specific contraindications for aspirin. And then these are just some others with your NSAIDs. Again, you could refer to some of the other aspirin contraindications. Again, with pregnancy, they're not totally contraindicated. If a physician prescribes them and feels they can be utilized, you can utilize them, but make sure it goes through a physician order. Certain types of antibiotics could contraindicate the use of NSAIDs. Antacid use in combination with NSAIDs could reduce effectiveness. So take a look at this slide and just note some of your contraindications here. NSAIDs effects on healing. So there have been concerns. Obviously, the inflammation phase is very pertinent to healing. And again, the drawback to inflammation when you're looking at the body trying to heal itself from an injury are the signs and symptoms associated with inflammation. Now, there have been some concerns that NSAIDs can delay healing in orthopedic musculoskeletal injuries, particularly with fractures. Now, there's no definitive evidence showing that its use is contraindicated in these situations, but if you take these medications during the immediate phase, there could be a slight delay in healing. So, again, if pain needs to be controlled, some people believe, particularly in those early phases, you should maybe think about doing something else and then using the NSAIDs a little later on to limit some of the other signs and symptoms. So this could be a philosophy that you discuss with your team physician, and there's some literature out there discussing some options for this. I know in a lot of circumstances, just as a personal experience, in some situations, I've delayed telling athletes to take NSAIDs for typically at least the first 3 to 5 days and just tried to control their symptoms with modalities, and if they had pain, suggested a non-NSAID pain reliever like acetaminophen to kind of allow the inflammation to do its thing early on. But again, that's something you could discuss with your team physician to see what his or her philosophy is on that topic. So this takes us into our other anti-inflammatory medications. We're going to look at corticosteroids. All your steroid hormones are lipid-soluble and they come from cholesterol. Now there are 4 types of corticosteroids. Again, we're going to be focusing on a specific type of corticosteroid. Anytime people say they're on steroids, they automatically think they're on anabolic steroids. This is not the same thing. There are 4 types of corticosteroids. They're all produced in the adrenal cortex. You have your mineral corticoids, more specifically your aldosterone. Aldosterone is responsible for maintaining a proper balance of electrolytes in the body, primarily sodium. Your glucocorticoids, your cortisol, this is what we're going to be looking at in as far as the medications and how they affect the anti-inflammatory effects of the body. Your glucocorticoids are your body's anti-inflammatories. And then you have your androgens and your estrogens, and these are basically your androgens are your precursor to male and female sex hormones, and obviously the estrogens are the primary female hormones. Again, these are not the same. When you hear people are on steroids and they're on corticosteroids, they're not the same as anabolic steroids. The anabolic steroids are derivatives of the male reproductive hormone testosterone. and they function a little differently. So your glucocorticoids are very potent anti-inflammatory medications. They, however, at the same time, can limit the healing of tissue and also possibly cause muscle atrophy. So we'll kind of talk about the benefits and drawbacks of utilizing glucocorticoids as a way of treating inflammation. So your indications and uses of prescription corticosteroids, certain skin disorders and reactions, nasal inflammation, asthma. These are some very common things you will see this with. Rheumatoid arthritis, GI disorders. Now the GI disorders will usually be autoimmune based that they subscribe this for, because what it'll do is that one of the physiologic effects of taking a corticosteroid is to suppress the immune response. So in things like ulcerative colitis and Crohn's, where the body's immune system is doing something it's not supposed to be doing, that could be a beneficial thing. For bursitis and inflamed joints, again, we had mentioned autoimmune diseases already. Another one of those would be lupus, where again it's another situation where the body's immune system is working on itself. And another discussion posed question, which I want you to kind of look in your reading for, is what are some other common orthopedic indications? Obviously, you don't, for every single orthopedic injury, you're not going to prescribe a corticosteroid for. So what are some of the more common orthopedic indications where you apply corticosteroids? As far as the pharmacodynamics are concerned, there is much greater suppression of the inflammation response with corticosteroids than with aspirin or NSAIDs. And again, as I had said previously, you also suppress the immune system. Now, in some situations, that could be needed. In some situations, it's going to be an adverse effect, because if you suppress your immune system, there's a greater chance that you can get ill. However, in situations where individuals have autoimmune conditions, those conditions need to be suppressed. So that's part of the reason why corticosteroids would be prescribed in those situations. They inhibit the formation of phospholipase A2. So what this does is it stops inflammation earlier on in the process than what NSAIDs and aspirin do. So I'll show you another picture of the chart going through the inflammatory response and show where this takes place. It is also going to limit white blood cell activity. Your corticosteroids are fat soluble, so they'll be stored in the body a lot longer. One of the drawbacks that you have with this is that they can cause the adrenal glands to produce less cortisol. So if taken for a long period of time, you can have some adrenal suppression. So basically, if you're taking something kind of artificially, your body doesn't feel the need to produce it anymore. So your body will kind of stop producing its own cortisol because of the fact you're basically supplying it through the medication. So here we go. We kind of keep coming back to this chart showing you how all these different drugs work. So we showed where NSAIDs and aspirin work and at what level. So again, they work at that point where the cyclooxygenase enzymes are created once through the breakdown of arachidonic acid. However, corticosteroids start their action much earlier, and this is the reason why they provide for a much greater suppression of the inflammatory response. So corticosteroids start their action all the way up at the phospholipid level, which will produce a much more reduced inflammatory response. There are various routes of administration for corticosteroids, and some things will be available in over-the-counter forms. For instance, your topical creams. Hydrocortisone, for instance, is a very common over-the-counter cream that could be utilized in topical applications. Nasal inhalants and sprays, lung inhalants and sprays, oral tablets and syrups. And obviously we know that it can be used as injections. We have steroid injections for, for instance, in inflammatory conditions at the joints. A lot of times what they'll do before they inject the steroid, they'll do what's called a pain ablation test, where they will first inject a region with lidocaine to see if the pain has been reduced, and if that's the case, then they know that the person could potentially benefit from the injection of a corticosteroid. So these are the various routes of administration. Again, some can be over the counter. I'd probably say most of them you will require a prescription for. Many different side effects and adverse reactions when you look at corticosteroids. Certain side effects are more common with certain routes. For instance, many people take a nasal spray of a corticosteroid. It's very rare to have systemic side effects from something like a nasal spray that people would commonly take for allergies. More commonly, what you'll see with the systemic side effects are usually through oral administration of corticosteroids. So a lot of these will depend on the administration routes. So if you look here at the list, I won't name every single one of them. You could see them on here. I'll just maybe describe some of them. You have to be concerned with diabetic patients. Cortisol does work against insulin, so your glucocorticoids will cause blood sugar to rise. We talked about the immune suppression. That, again, is sometimes an effect that people are looking for depending on the situation, but if it's not, it can be an adverse reaction. Cushing's syndrome is a situation where there becomes an overproduction of cortisol, and you can see in the picture on the side that one of the classic symptoms of Cushing's syndrome is what's known as a moon face, where the patient gets a very round facial appearance. So take note of those along with the other side effects and adverse reactions posted here. And some other side effects and adverse reactions. So a lot of potential for some other orthopedic complications potentially. You've osteonecrosis of the femoral and humeral heads, so some issues that can develop there. Like NSAIDs, there's the potential for stomach upset and even gastrointestinal ulceration. Again, particularly if they're combined with alcohol or NSAIDs, just because of the added irritation that could take place there. Your skin irritation can occur from topicals if the person has an adverse reaction to it. And then some other issues, as you can see in the list here, the suppression of the adrenal glands, which we've already talked about. Again, that's going to be basically because of the fact that the adrenal glands in the body will kind of get lazy because they will think, well, the person's taking in the cortisol, therefore, we don't have to produce it. So that's going to be the main reason why the adrenal glands decrease their activity with that. And then a few more side effects and adverse reactions. Eye pain, visual disturbance. Again, we kind of talked about general GI upset, mentioning that again. Fluid retention and edema, increased bruising because of the excessive cortisol in the body, menstrual irregularities, prolonged signs of infection. And again, that's just going to be because of the suppression of the immune response. And it can cause diabetes because of the fact, again, the issues with regulating blood sugar in the body. So your pharmacokinetics for oral dosing, because this is where going to be some of the more complicated issues with this comes in. If being used for a longer duration, you have to taper off. So if you're using oral corticosteroids and they're being taken longer, you can't just stop taking them, okay? What's going to happen is you're going to have to taper off because your body's going to have to get used to not having the outside supply of glucocorticoids being supplied to the body. So to make sure that the person doesn't have a drop-off because their adrenal glands aren't producing it, you have to make sure that the individual tapers. So it can cause adrenal insufficiency and a lot of other signs and symptoms associated with that. So, and after prolonged use, abrupt discontinuation could also be fatal, particularly if the person goes into an adrenal crisis. So, and all this really involves is just the individual taking smaller doses over a period of time. Again, that'll be up to the physician depending upon what the actual condition being treated is. Even in a lot of instances, what will happen is sometimes, even with short doses, they will use a taper period where they'll kind of hit whatever condition is being treated with a very high initial dose for a first couple days, and then what they'll do is they'll wean the patient off even over the course of a week to 2 weeks. But definitely if being longer for 2 weeks, they must taper off of this. These are metabolized by the liver, and again, if the consumption can be kept to less than 1 week, they'll do this to prevent side effects. Again, even with a 1 week period, they may still need to do a taper. So it's just be mindful. This is a type of drug where if taken orally, it can't just be stopped abruptly in many instances. So these are just some considerations. An individual who has any of these conditions should consider not using the corticosteroids. So just make note of this list. In a lot of instances, it just has to do with immune suppression or anything affecting the gastrointestinal tract. So as far as considerations for use, inhaled corticosteroids are very commonly utilized by people for various issues, be it for allergies or asthma. These are not a concern for drug testing. They don't affect testosterone. Again, remember, all of these things are steroids, but there's a difference between anabolic steroids and corticosteroids. So again, there's not going to be a concern for drug testing there. If you're in regards to oral corticosteroids, the best thing to do is just check with the governing body just to make sure. The only corticosteroid that does not require a prescription is topical hydrocortisone. Again, you can buy topical hydrocortisone in any drugstore. The one important point to know is they do inhibit collagen synthesis, so there can be a delay in wound healing if an individual is taking dosages of corticosteroids. So it's one of the drawbacks to their individual use. And these are our learning outcomes. So again, a lot to talk about here with anti-inflammatory medications. Again, in our patient population, probably the most commonly, or at least one of the more commonly utilized drugs. So it's a good idea. Again, there's certain depth with these drugs that I probably won't ask you to know for other types of drugs, just because of how commonly these are used. So again, be able to recognize, where drugs kind of land as far as what type of anti-inflammatory drug they are, and obviously if I gave some specifics as far as dosages, make sure you're aware of those as well.